step. If he's only having monosyllable babbling, we can't suddenly expect him to tell a sentence. So the next sentence is, next step is maybe how do we stimulate him to come to bisyllable babbling. Once he is on bisyllable babbling, then how do we get him? What is the best way to get him to say words? How can we stimulate? Then there are things that are bad or that are sort of, if you take speaking, screen time is very harmful. So we must make sure that the screen time is taken away. So like that. That is how you reinforce the skills that are already there and teach developmentally appropriate skills. And then you can use other skills to overcome the difficulties, provide the missed experience. And you can use different learning styles to promote learning. So that's why we do that. So when do we suspect abnormal development, right? So one presentation can be that history from the parents. So history from the parents. So if we wait for the parents to bring the child to us, it has been found that it is only 75 to 80% sensitive, because the parent also should be alert. They also should know something. They should be, sharp enough to identify. So only 80%, maximum 80% patients we will see. In identifying normal, it's only 70 to 80% specific. So it's not 100%, not even 90 odd. So therefore, it's not good. It's not very. It's not 100% cool. The parents to come up with it. This is why it is important that we need to screen all babies with development assessment. Because if we don't screen, they may present late to us and they may miss valuable time in their life and they will fall behind their peers, which may mean they might have to go to a special school, or they'll be behind in their school. They will not be able to face the public exams, and they may be treated like a retard for the rest of their life. So we have to prevent that, and we have to get these children, even if they have small to suspect abnormal development. So whether we are going to wait, why we cannot wait until parents present to us, right? The reason why we don't wait until parents present to us is because it's only 75 to 80% sensitive and 70 to 80% specific. Meaning sometimes, only 80% of parents will present. So 20% of the children, that is 1/5 of the children will be missed. And that is not good enough. So this is the reason why we can't wait only for parents to come and tell us, and why we need to check and identify these children early. So we need a screening to screen all children with regard to developmental assessment. Then if we talk about abnormal development, so there are two main types. One is that there can be a delay in the acquisition of skills. So for example, the baby is now 6 months old, but still has not developed head control. He is still not smiling with his mother. But say at 8 months, now he has developed head control and he has developed smiling. So it's slow, but he's getting the skills. What is meant, the other pattern is developmental regression. So what it means is loss of previously acquired skills. Meaning now this commonly will happen either due to some structural, it can be a tumor, brain tumor, or it can be a brain infection like a meningitis or something that happened in a child who was developing normally, or there are other disorders, metabolic disorders, which causes issues. So in this, what you will see is, let's say a 9-month-old child who was developing well, who was able to say crawl and even stand with support. He was able to have some pincer grip. He was saying bisyllable babbling. He was able to clap. All that was there. But now this child, like say from 2 weeks back, is starting to lose the skills. Now he is unable to even lift the head. He is unable to reach out. He is not saying any words or any sound at all. So there is a loss of the acquired skills. So you must be able to identify these two patterns. In both instances, the development is abnormal. If there is loss of skills, we say there is developmental regression. If there is delay in acquiring the skills, we say that there is developmental delay. Are you all okay with that? You can ask me if it is not clear up to now. Okay, so during this module, our emphasis is mainly on normal development, because this is basically preparing you to face your first pediatric appointment as well, right? So we are not going to talk about developmental regression and the reasons for that. We will focus more, because that is a lot to do with neurology. Doesn't make sense to go into etiology before you all do the neurology module. Right? So if you just know the principle, what is meant by developmental regression, that is more than enough. But we are going to go into a little more detail with regard to developmental delay. There is a question, right? Madam, is a loss of just one skill? Yes. Even if there is a loss in one skill, we will consider for that domain that there is a developmental regression. So now you have to listen carefully to see how we are going to describe developmental delay. Right? So for every development milestone, there is an average age at which they acquire skills. So for example, if we take head control, the mean age is 4 months, right? Then there is what is called a limit age, right? A limit age is the age at which a skill should have been achieved by, let's say now, all population stuff, everybody doesn't do everything at the same time. So more than 2SD of the population should have achieved this skill. So if there's a deviation of more than 2SD from the mean, that means they have passed the limit age as well. So for example, say the usual age a child acquires head control may be 3 to 4 months. But if by 4 to 6 months also there is no head control, that is definitely abnormal. And that will be considered a significant delay. So a significant delay is defined as performance 2 standard deviations below the mean age. Then it is easy to quantify. So because then comes the question, how do you know where this 2SD is for each development milestone, right? Or for each development domain. When we talk about development, I think it will clarify the previous question also. First, we have to assess development with regard to different domains. We can't consider everything as a whole. Right? So always development has to be considered with regard to each domain separately. Right? So for each domain, you have to get the developmental age. That is, what is the developmentally, if you take the milestone, what is the age? And what is the chronological age? Chronological age means, but from birth date to now, when you calculate how many months or how many years. So developmental quotient is the developmental age divided by the chronological age times 100. So for example, we take a child is 1 year old and the child can only lift the head with support. Right? So can I ask you, what is the developmental age for that gross motor for this 1 year old child?
3 months.
Sorry?
3 months.
Yeah, let's say 3 months, 3 months or 4 months. Good. And what is the chronological age?
1 year.
1 year. So if we are writing it as a fraction, how will we write?
3 upon 12.
3 upon 12. Very good. So that is 1/4 into 100. Right? So we will get it as 25%. Right? So that is how you calculate the development quotient. Okay. So if we try to interpret that, right? So the maximum score, for example, if we say 1-year-old child can walk without help, then that is what they should be doing. So walking without help, maybe even 15 months milestone. So that will be 15 upon 12, which is more than 1. So then the maximum score will be more than 100. So how do we interpret? If we are getting more than 85%, that means it is normal development. You can get advanced development as well if it is more than 100. If it is between 71 to 84%, there is mild to moderate delay. If it is less than 70%, it is severe delay. So now in our example, if you were listening, 1-year-old child could only lift the head couldn't lift the head. So we took it as development age for the gross motor is 3 months, chronological age 12 months. So that is 1 upon 4 times 100 is answer is 25. So considering that, what sort of development, how will we categorize this child's development according to the development quotient? Which A, is it delayed? B, what type of delay is it? Atukorala? Atukorala? Are you there? Herath?
Score is 25%. It is less
Yes.
than 70, so it's severe delay.
Very good. Right. So that's how you interpret. And sorry, this is only for gross motor. Good. Right. So now we are moving on to types of developmental delay. Right. So there are 2 main types. If you are asked in a question, every time you get a question from development, right? You are asked, how would you describe this child's development? So what is meant by that is, are we saying it is a specific delay or is it a global delay? So from the meaning of the English word, specific is only that. So for example, if I go on with my example of that 1-year-old child who is unable to raise the head, right? So let's say that child cannot raise the head, and if you look at fine motor, the baby is not reaching out, he is not fixing or following. So that is even less than birth. So his fine motor development is almost 0. If you take speech, not making any sounds at all, again 0. No social smile, so again 0. So you can see more than 1 and no interest in new objects. Cognitive also 0. So all the areas are affected. So in this case, significant, you should know the definition of this. Say, if there is delay in only one domain, we call it the specific development delay. If there is delay in more than two or more domains, we call it a global developmental delay. So in the example I gave you with the 12-month-old child, what do you think the delay is? Is it a specific developmental delay or global developmental delay? Lakshini?
Hello, madam, can you hear me?
Yeah.
I didn't hear the question.
Okay, we were talking about this 12-month-old baby, right? The one we use. We said gross motor, 3 months. Gross motor baby cannot lift up the head. Right? So what is the developmental age there, Lakshini?
Three.
Around 3 months. How do we calculate the developmental quotient?
3 divided by 12 into 100, that's 25%.
25, very good, right? So we also said that if it's less than 70%, it is severe delay, right? Okay.
Yes.
Then if we take fine motor, baby is not reaching out, not fixing, not following. So what is the developmental age in this same child?
Even before, it's 0.
It's 0, right? Now, if I tell you about speech, not making any sounds, only shouting.
Then also it's 0.
Again,
So
zero.
if
Then
there's more than 2 or more domains are affected, then that is global development delay.
okay, very good. So that is how you sort that one out. Good. So I'll give another example now to maybe somebody else. Kumara Singha. Okay, so the Kumara Singha, KKAVP. There are lots of
Yes, madam.
Right. Okay. So let's take another example. Right. Now there is a 2-year-old child who can stand with support, but unable to stand without support. What is the developmental age?
12 months.
About 10, no?
Oh, yes,
Usually
madam.
by 12, they should be able to stand without support and they should be able to walk with support. So let's say it's about 10 months.
Okay,
Right?
madam.
So how do we check the developmental quotient? 10 divided by
24.
24. Good. So it's about half, right? Less than half also. Then let's take fine motor development. This child is able to draw vertical lines.
That means the child's fine motor development is okay.
2 years, right?
Yeah.
So it's 24 upon 24. That means it's 1. That's okay. Then let's say if you take the speech development, the child is able to say 2 to 3 word sentences.
That's also, madam, the development
That is
age is
also
2 years.
yeah.
Yeah.
And let's say social development, child is able to feed herself with the cup and the spoon.
That's also okay.
That is also okay. And if we take the cognitive development, he is able to put a 2-piece puzzle together and he is able to make put couple of blocks on top of each other, say 7-8 blocks. So meaning cognitive development also okay. So in this situation, how would you describe this child's overall development?
The child's gross motor development is below 80 and his other development domains are okay. So that's specific development delay.
So what type of development delay? We are now talking to say whether is it a specific delay or a global delay.
That's a specific delay, madam.
Yeah, so you have to say it is a specific developmental delay which is limited to the which domain?
Gross motor.
Right, very good. So that is how you sort it out. Now, does anyone have any questions? You need to know this thoroughly, right? Every year you get a SCQ on this. So your SCQ will be just like what I told you. If you understand today's lesson, if you study your milestones, you should be able to get near full marks for that. Okay, because what you are expected to do is you will be given a situation. You have to name the domains, name what are the milestones, name the ages. Then we have to figure out is there a delay or not. If so, is the delay limited to one domain or all the domains, or not all the domains, or is it specific or global? Is it 1 or more, 2 or more? Okay, so if you are okay with that, let's proceed. Anyone having any questions? Okay, so then we'll go on to more about developmental screening, right? So when is it done? Who does it? Using what tests? So can someone tell me, is it done in our country? And by whom and when? If it is done. Kitulwatta? Sirina? Do you think development assessment is done? Screening?
Yes, madam. In CHDR also,
Yes, very good. So do you think who should be doing
there
the
is
first?
a lesson.
Yes, there is in the yellow
I
pages.
think
Yeah.
mother,
Yes, sorry, who does it?
I think midwife will ask from mother that they do this
Yeah,
gross
you
motor
are
and the
correct.
fine motor activities.
Yeah, the milestones are written there. Did you see? The first column is for the mother to fill. Right, so mother is supposed to check it and mark it and alert the midwife, and midwife on the house visits are supposed to double check that the mother is doing it correctly, and she also should assess. So the development screening happens for every child via the CHDR, right? And it is done by the mother and the midwife. So here is a page from the CHDR. You can see it is in Sinhala and in Tamil. Then they give for each age what are the milestones that need to be checked. Right, so the 3 columns are there. First, the mother has to tick it, and then the midwife will also have to ascertain. And right, සිදුවන විට වයස තහවුරු කරන විට වයස. So first, when it starts, when it's established, and who is the person who confirms what the mother says, right? So it says that the double star one, right, is the first column is for the mother to fill, and the second column is for the PHM to check. Right, and if there is a concern, the baby should be referred. And when they go to the MOH clinic also, they should make sure that the child is okay. So these are the pages, right? You can see the pages that have සති 6 සිට මාස 3 දක්වා from 3 to 6 months, 6 to 9 months, 9 to 12 months, 12 to 18 months, and there are different ages like that. They have given the milestones, right? Not a lot, but I think like one from each domain, the main milestones from each domain during that age group, and development until 5 years old can be assessed using the CHDR. And these pages, the yellow pages, are showing what are the things that should be done. What are the development milestones that is expected of this child? That is for the education of the parents and also the midwives as to what is expected. Right. So there are different types of screening tests. You don't need to know in detail how to do this. If you know how to do what is there in the CHDR, I think that is enough. So there are different names, right? This is a nice to know thing. We talked about blocks yesterday, how at different ages they can put 2 blocks up at 15 months, 5 to 6 blocks around 2 years, and at around 3 years they can put about 9 blocks, so like that, and they can make a bridge at a certain time, right, staircase at a certain time, so that is blocks. Gesell figures is we talked about that they can draw vertical lines at 2 years, a circle at 3, square at 4, triangle at 5. So that is the blocks, that is the figures. Then good enough Harrison drawing test, I will get to it in a minute. We talked about there is what is called the draw a man test. By looking at a man, a human figure a child is drawing, we can estimate the age. And in addition, there are other tests which come with separate kits called the Denver Development Screening Test and the Bailey Screening Test. So these are some pictures drawn by children, right? So you can see which we are scored. So you can see the more details there are, the more clearer the picture is, score is higher. So this is how we actually score, right? So this sort of thing can be given to you at your pediatric appointment, especially at the professorial appointment or once before at OSCE. You are given a picture of something like this that a child has drawn, and you are expected to get the age, right? So how do we calculate? When you can draw a circle, you are 3 years. So that is why it says mental age is equal to 3 plus. Then you give 1 mark for each feature. For example, in this picture, now the hair has been drawn. So 1 mark for the hair. Then head, circle for the head, 1 mark. Then the eyes, 1 mark. nose, 1 mark, mouth, 1 mark. If you draw 2 lines and draw like a 2D effect, you get 2 marks, right? Then the neck, 1 mark. If it is joined to the body, you will get 1 mark. Here the neck is not joined, right? So therefore only for drawing the neck. Then for drawing 2 arms, you get 1 mark. But if you put 2 lines to draw the 2 arms, you get more marks. If you put fingers correctly, you get more marks. So like that, right? You get marks for this, and when you count all this stuff, you get 13 points. So how do we calculate? 3 plus the number of points divided by 4 will give us a rough idea of the developmental age of this child, right? So it comes to around 6¼ years. Right, so here are some more pictures that have been drawn by 6 years, 5-month-old child, 6 years. So the more details they put. Now this guy you can see there are socks and shoes and clothes, and they have drawn fingers, but there are 5 fingers are drawn. So all those will get marks. So this is the good enough Harrison drawing test. You don't need to learn what this is. It is just important to know. So this is the guide as to how marks are given in this situation, right? These are the rules basically. So if you know there is something like this, that is good enough. You don't have to remember all the rules in this test. So these are the block test and the figure test, right? So a child who is 3 to 3.5 can build the bridge. 3 to 4.5 can build the gate. 5 to 6 years can build steps with blocks. Again, drawing a circle is round 3 to 3.5. 3.5 to 4 is cross. Same is square, or 4 to 4.5 is actually square. And 5 to 6 years is the triangle. So once we get, like from a screening test, if the child is showing any signs of delay, we have to do definitive tests, right? So even in the field, if you suspect the child is having a problem, the child should be referred to a pediatrician, who will then carry out more tests to ascertain whether this child is actually having a developmental delay. So there are different tests that can be carried out. These are some of the names: Bailey Scale, Stanford Binet, Wechsler, and Darcy 2. So there are some factors that affect the development assessment, right? So people have to be in the optimal condition before we assess development. Now the baby, if it's in a really bad mood, that should not be the time to assess development. Baby should not be hungry. Baby should not be sleepy. They should be alert and awake and not ill. So when the baby is coming with some illness to the hospital, that is not a good time to check development. You'll have to wait until the baby is better. Ideal time is midway between feeds, right? So after, not soon after a feed, they might sleep. So it may be after they wake up and they are alert. Again, the examiner should not be in a rush. If I have 10 minutes for a meeting, I shouldn't undertake to do a development assessment at that time, because I'll be looking at my time, right? And then you have to use appropriate toys and gestures. So this is important for you. When you're carrying toys to the pediatric ward, there is no point giving a book. Well, let's say a book and asking a child to read at 6 months. You can see whether he pays interest to the pictures when you show, right? Whereas a block or a ball or something like that might be more appropriate. There's no point giving a rattle to a 1-year-old child either, right? So that is why you must use age-appropriate developmental toys. Then about the environment. The environment should be free of distractions and not cluttered with toys. So when we are doing developmental assessment, only one toy should be given at one time. That toy should be removed and a different one given. Otherwise, the baby will get distracted with all the other stuff lying around, right? So these factors are important in order to successfully assess the development. Okay. So now after this, so these are basically the principles that are used in development assessment. After this, we are going to see how we assess development in different age groups, right? So if we take birth to 6 months, we do what is called a 360-degree assessment, meaning just checking in one position is not good enough. We start with supine position, that is the baby is lying down with the face up, right? You keep the look at the posture, you see whether the baby can keep head in midline, right? If you remember your milestones, they can keep the head in midline only around 3 months. Then once you look at supine position, in the same position, you pull the baby up with the arms. And with that, you assess the tone, head lag, sorry, spelling mistake, head lag and the back shape. Then you have to lift the baby up, that is called the vertical suspension, and you check weight bearing. You saw all this earlier. And then you put the baby down, face down, right? And at the same time, you check the primitive reflexes. With regard to fine motor assessment, you place the infant in the supine position and you observe the hand skips. You see whether there is hand play, which if you remember, it comes around 3 months. Then you give a small block, which is small enough for the baby to grasp and take for palm grasp. At the same time, you check whether there is fisting, meaning some babies keep the hand closed, right? So that should fisting, they should be keeping their hand open in the first 3 months of life, progressively more open. Then hand regard, is the hand play. Then mouthing, we said happens around 6 months. Then whether they can bring the hands to the midline. So we offer a toy. So a toy would be something small, maybe a rattle or maybe a small block that baby can grasp. If you give them a very big toy that they can't actually hold, we actually cannot assess. So whether they are reaching out, whether they are able to hold on to it, whether they are able to transfer. Then about the social skills, right? We can keep the baby facing the parents, facing us, and check if there eye contact. If their lack of eye contact can be detected as soon as they are born, even soon after birth, babies have eye contact. Babies can fix and follow. So soon after birth also we can actually get some issues, after which we should refer. When we show the child a toy, does it fix? Does it follow? So again, if you go through your development milestones, you will see that at 1 month, they are expected to follow 0 to 90 degrees, right? And then by 2 months, 90 to 100 and between 90 to 180, and they are expected to follow the full half circle, that is 180 degrees by 3 months. Without touching, if we smile at the child, what does he do? Does he respond with a smile? Then we should also test for mouthing. You can also ask from the mother, right? But now developmental assessment is a short case in your final year pediatric assessment, and there you cannot talk to the parents unless the examiner says so, because we are assessing your skills of whether you can do this. If you take the cognitive skills, we can present a new toy, check whether he's interested. Then we can take the toy out of his visual pathway and see, okay, does he still look for it or not? Has he forgotten about it? That's called object permanence, right? And what is the reaction to strangers? If we look at red flags from birth to 3 months, right? If the baby starts to, stand up or roll, that means there is hypertonia. So that is a red flag. If there is persisting fisting at 3 months, that again is a red flag. If the baby is not alerting to environmental stimuli, that again is basically, if he is not alert to sound, alert to smiling, that would come as a red flag. If you take red flags from 4 to 6 months, right, poor head control, again would be, you have to check for hypotonia, failure to reach out for objects by 5 months. We have to think of whether there is a motor problem, whether he can see, or whether there is a processing problem. So it can be issues with either motor, visual or cognitive, or it may involve everything. If there is no smile, what can it mean? It may mean there is a visual loss, it may mean there are attachment problems, it may mean maternal depression, because if the mother is never smiling with this child and nobody is ever smiling, obviously the child also will not know to smile back, right? And if no one is paying an attention, if the child is being abused, again the child is not going to smile, right? So before we go to the next age group, right? I will show you a video. All the videos are uploaded onto your LMS, so please have a look. So I'll try to play you one now. Hold on.
Periods, while
Yes,
the
madam.
developing baby on the right has a more
Are you
predominance
able
of
to see
head
the
turning to
video?
one side and
Yes,
strong
madam.
ATNR, asymmetrical tonic neck reflex. Visual tracking. Notice the typically developing baby can locate the object, but has difficulty visually tracking, and only tracks objects to midline. Extremities. See how the infant on the left begins to show extremity anti-gravity movements and reciprocal kicking, while the atypically developing baby on the right has long periods of inactivity, few anti-gravity movements, and less reciprocal kicking. Position 2, sideline, transition. The baby on the left shows lateral head righting and follow-through into rolling with head lifted into prone. Baby on the right can remain in sideline without rolling by flexing his hips and knees, increasing his base of support. Trunk control. The baby on the left is able to switch from using abdominals during the roll to neck and back extensors as he completes the roll. The baby on the right is in a position that doesn't require him to work as hard against gravity. So in this position, he looks more symmetrical. Movement. In this position, the typically developing baby demonstrates an integration of major muscle groups. The atypically developing baby on the right looks more confident in this position. Therefore, it is important to observe in more than one position. Position 3, prone. Head lifting. The typically developing baby is able to lift 45 degrees while extending through the upper thoracic spine. Baby on the right still has a newborn posture. He shifts his weight forward towards his head, making it harder to lift. Head and upper trunk. Baby on the left's upper body is free to lift his head and upper trunk off the surface. Note that the changes in leg position on the atypically developing baby allow him to begin developing head and trunk control. Hip position. Watch baby on the left moving out of flexed into flexed in adducted position, while baby on the right remains in flexed in abducted posture. Movement. Notice the baby on the left is doing little weight shifts and is able to counteract with his abdominals to balance while increasing shoulder girdle strength. Baby on the right strategy is to extend and push up on his legs. It doesn't assist him in lifting his head and pushing up on his arms. Position 4, pull to sit. Head. The typically developing baby demonstrates head lag, expected at this age. He sustains midline head control when upright. The atypically developing baby demonstrates head lag throughout the maneuver and poor head control when upright. Upright. Baby on the left is upright. He has good extension through the cervical and upper thoracic spine. Baby on the right has little activity in the cervical spine and rounding of thoracic and lumbar spine. Upper extremities. The typically developing baby uses shoulder elevation and elbow flexion to assist in the maneuver. The atypical developing baby is not able to use his shoulder girdle to stabilize upper trunk during the maneuver. Position 5, sitting. Head. Baby on the left's head is aligned with his ear, directly over his shoulder. Baby on the right is unable to achieve and sustain head lifting in an upright position. Posture. The typically developing baby has good activity of the neck extensors. He is able to hold and sustain posture with assistance. The atypically developing baby needs more support to sustain a sitting posture. Movement. We don't see a lot of head turning in this position for the baby on the left, but this is typical of this age. Baby on the right's arms are inactive because he lacks shoulder girdle strength. Position 6, horizontal suspension, anti-gravity extension. In this position, the typically developing baby's muscles of the neck and trunk can sustain this posture against gravity. We can see in this position the atypically developing baby is unable to lift his head or activate his neck and upper thoracic extensors. Extremities. The typically developing baby recruits muscles in the shoulder girdle to augment the thoracic extension. The atypically developing baby moves his arms and legs to stabilize his trunk, which is a non-productive strategy. Position 7, protective extension, tilting forward. When we tilt the typically developing baby forward towards the surface, he sustains and increases the head and neck extension. As the atypically developing baby on the right tips forward towards the surface, he is unable to lift his head and extend his trunk. Progression. The typically developing baby on the left is on track to demonstrating fundamental control in this position by 6 months. Note that if the atypically developing baby does not get early therapy to develop head and trunk strength, it is unlikely he will do this position by 6 months. Position 8, standing, posture. When placed in supported standing, we see the typically developing baby has good vertical alignment from head through trunk and feet. Notice the atypically developing baby on the right sustains pseudo-extension when provided maximum support. Upper body. Note that the typically developing baby uses shoulder elevation, and his upper extremities are held close to his body to assist and sustain this posture, while the atypically developing baby has little or no intermittent muscle activity to maintain standing. Weight bearing. The typically developing baby sustains weight on lower extremities with trunk support, while the atypically developing baby collapses into flexion when the examiner tries to let him take weight on his feet.
Okay, so there are many more videos, right? That was the one at 2 months. There are also videos at 4 months and 6 months, which are comparing normal and abnormal development. It might help you to have a look at it, right? Okay, it's already there in your LMS, right? So if we take a like slightly larger age group now, 7 to 18 months, right? So again, when we talk about gross motor development, it's similar, right? Where there's a 360-degree assessment, where we start with the supine position, with looking at the posture, the way that the baby is able to keep the head in the midline. Then we pull to sit, we look at the tone, the head lag, the back shape, right? Then vertical suspension, prone position, and you still check for persistence of primitive reflexes, because if primitive reflexes are present after 6 months of age, that means it will obstruct voluntary grasp, right? So if still the palmar grasp reflex is there, it will be an inhibitor towards developing of the voluntary palmar grasp. So you have to check for primitive reflexes as well. Right, so now in this child who is a slightly old child, you introduce yourself to the child as well as the parent, build up a rapport, sit the child on an appropriate chair or in the children or in the parent's lap. We offer to test their vision, ask the parent if they have any concerns. We can offer the piece of paper that has been wrapped up into a small ball and comment on the piece of it. Or you can have a little, bead-like thing which is tied to a string, which can also be used for this. But you have to be safe. You can't afford the child to have accidental swallowing of a bead. So you have to be careful when you do this, right? So with regard to fine motor assessment, we can also offer the child a brick. Brick means like, building block or something like that. That stuff that we did with blocks. Whether it is the child reaching out, is he getting it, is there palmar grasp, is he able to release it, So first thing is getting it, next thing is releasing. Can he bring two bricks together from either hand? What will he do if you offer a third brick? When we build a tower, can he copy it? So we have to, there are a lot of things you can do with blocks. So that is one of the important things you should have with you when you are trying to do a development assessment on a child. There's another thing you should have. We saw there are a lot of things we can learn from what the child draws. So a piece of paper and maybe some crayons, right? And by offering it to it, you can see, does the child take it? If they take it, you have to see what sort of hold does he have. Is it the shaft hold? Is it the holding with thumb and third finger but not tripod grip? Then like that, you have to assess the grip on the pencil. And also on what they are drawing. Are they drawing lines? Is it scribbling? Like that. Then you can offer the child a picture book, right? So that is another thing. You can have a small picture book with one picture per page, right? So there are a couple of things. One is he interested in looking at it. And how do they turn the pages? Are they able to identify the object? Sometimes when you tell them, okay, what is the object, they may be able to name it. That is called expressive language, right? Or when you say, show me this, they may be able to show us the object, although they can't name the object. That is called receptive speech. So if you show a child with a couple of pictures and say, can you show me the ball? If they point at the ball, that is called receptive language. Or if you show the ball and ask the child, what is the ball? And they reply ball, that is expressive language. Then cognitive skills at this age, you give a new toy, you look for interest in new toys, look for object permanence, meaning you hide the object in front of the child's eyes and then you see whether they can get it. They know that we have hidden it, right? If they can find it, that is called object permanence. Then when we present a familiar toy, right, say her own toy, how does she react to it? Does she recognize it? He or she. And what is the reaction to strangers? Because you will remember that strange anxiety comes around 6 to 9 months of age. So what are the red flags at this age? Red flags from 6 to 12 months would be the persistence of primitive reflexes after 6 months, right? If they are there, we have to evaluate for neuromuscular disorder. Absent babbling by 6 months, right? So if another cardinal point that you need to know is, if the speech development is delayed, the first thing, the most important thing, or the first thing you have to check is whether the child can hear. So we have to evaluate for a hearing deficit if there is no babbling by 6 months. There is no strange anxiety. So we expect strange anxiety to happen around 6 months. If you have encountered children, you will know that children younger than 6 months are actually very friendly and they will be happy with anyone. They like to play with anyone. But slightly bigger children are a bit wary of strangers and it takes a little more time and effort to become friendly with them. Sometimes they may cry as soon as it's somebody else, right? So if there is no strange anxiety by 7 months, it may be that they have lots of carers. For example, a child in an orphanage or in a home may not have any anxiety because every day their carer is changing. Whereas someone who's looked after, let's say, as at home with the mother or someone else, they are very apprehensive in going to somebody else or playing with someone else. Right. Similarly, inability to localize sound at 10 months, we have to check for unilateral hearing loss. Now, we said mouthing happens around 6 months, but it goes away around 12 months and then the baby starts to throw things around 12 months, right? So if mouthing is still persisting beyond 12 months, that might indicate a lack of intellectual curiosity. So maybe some issue with cognitive issues. So if we talk about speech and language, right? Speech and language is assessed using 4 different aspects. There is expressive language, attention, concentration, understanding of the language, that is the receptive language, and the size of the vocabulary. What do we mean by expressive language? So we have to observe closely and comment on what they are doing. So if the child says, "Mommy, carry," Or mommy, let's go. In our context, when they don't want to be examined, they say apya. And that, although it may be annoying that they won't allow you to assess, it's still a two-word sentence, right? So you can say, okay, this child is putting two words together, which makes sense. We have to try and talk to them, maybe say your name, ask their name, show them an interesting picture book. So whatever noises they make, sounds they make, words they use, any phrases, sentences, then can they tell us a story? Is the language they are using, is it grammatically correct? Those are the things we will check in expressive language. Attention and concentration, you observe the child in whatever activity he or she is engaged in. You look at the child's ability to look, listen, and concentrate. You try to distract them by pulling their attention to some other activity. And you can comment on child's attention span and how long they spend on each activity. How long do they spend with a toy, a book? How long can they sit still? And are they constantly changing? Then about receptive language or understanding language. So you assess it by looking at object recognition. As in, you give them a cup, you remember symbolic play. So if they put it to their mouth, although they can't name it's a cup, that means they recognize the object. If you give them a bell, if they start ringing it, that means they recognize the object. Picture recognition. So there you can see, they will start smiling, sometimes they start making animal noises when you show them pictures of animals. So you have to see whether there is picture recognition. Then ability to carry out instructions. We can say, show me your hair, or show me your doll, show me the ball. You give certain options and you ask them to do that, and that will show you understanding of the language. So if they can point at a picture in the book on our request, that is receptive language. When we ask them what is this and they can name the object, that is called expressive language. Also, they can show us the object by use. That is what I said, when we give a cup or spoon, if they put it in the mouth, they are showing us that it's used for eating. That is meant by object by use. Then ability to carry out instructions, giving instructions to the child. So the younger the child, we give simple instructions, and the older the child, you increase the instructions and see whether they can carry out the instructions. But the instructions should be appropriate for the chronological age. So then their understanding of grammar. So there are, in developmental testing, we have different objects to see whether they understand the concept of big and small. We have pictures of action words like running, walking, drinking, right, which we ask them to identify. Children usually learn nouns first, which is followed by verbs. Then prepositions, adjectives, negatives, time, all these concepts need to be tested as they grow bigger. So the size of the vocabulary, by 12 months, they are expected to say about 5 words with meaning. By 2 years, about 50 words with meaning. And the amount of words they are expected to meaningful words increases with the age. Right? So moving on to cognitive skills at 1 to 3 years, right? We are looking at how they explore new toys and experiences. Does the child explore the toys? Do they use it? Can they solve problems? When the 2 bricks are offered, do they know that they can pick up with either hand? And how can they collect a 3rd brick? What will they do if the toy falls under the table? Do they know to look under and get it? Can they complete a simple puzzle? We usually start with a 2-piece puzzle. Then what about bricks? Can they do a brick tower? What can they draw? So all these will help us to assess the cognitive skills. Then if we think about the red flags at this age, right, lack of consonant production by 15 months, evaluation. If there is no consonant production, we have to look for mild hearing loss. So consonants are, if you don't remember, consonants and vowels, right? Vowels are a, e. Those are the sounds that come when they are cooing. So after that come the consonants. Putting consonant and vowel together, only the monosyllable babble comes, like ba, like that. Then lack of imitation. If you remember, we did something called domestic mimicry, right? Mimicry, where you see the child is trying to sweep, looking at the mother sweeping. The child tries to imitate the things we say. So if there is no imitation by 16 months, we have to check whether there's a hearing problem, and we have to evaluate for cognitive or socialization deficit. Hand dominance. What is meant by hand dominance is whether can we say, does the child have any preference to use left over right? So until the child is about 3 years old, they should not be having any hand preference. So hand dominance prior to 18 months might mean the side they are not weaking is weak or having a hemiparesis. Inability to walk up and down stairs at 24 months. So if they are unable to hold on to the railing and up and down stairs, it may be more like a motor deficit, more like a lack of opportunity rather than motor deficit. Lack of opportunity means sometimes it may be the first child, precious child. So parents are scared to leave the guy on the floor, always carrying the baby. So he has no opportunity to explore. And that may be the reason rather than having a motor problem. So like that, depending on what the problem is, we have to try and figure out what is wrong. Then again, some more speech red flags would be if there is a delay in language development, it requires hearing loss. But if there is different type of non-communicative speech called echolalia, you have to evaluate for different diseases like developmental disorders, autism, stuff like that. Okay. So I will try to show you another video at this stage. Hold on.
Get out. You want that? Okay. Lots of toys, huh? Oh, let's do this. Can you put this one out? Did you want that? Yeah. Try to get that off, huh? Dad did that. Can you put the cap back on? Can you give me the paper? Can you give me a piece of paper? Can you give me a piece of paper? It's not working, is it? Where's the ball? Where's the ball? Can you get the ball? Can you? There. Good job. All right. Can you kick the ball? Can you stand up? Can you stand up to kick the ball? Stand up. Oh, I got it to work. Can you kick the ball? Good, good. You gonna kick the ball? Get the ball. Here's the ball. Get the ball. Here's the ball. Can you kick it? Can you kick the ball? You can. Can you throw the ball? Can you throw the ball? You throw it. Throw the ball. Throw the ball. Very good. Kick the ball. Can you kick it? Can you kick it? Kick the ball. Can you kick the ball? Can you throw it? Very good. Let's see if you can kick it. Can you kick it? We're going to show some pictures. See those pictures? Okay. Where's the kitty? Show me the kitty. Can you point the kitty? Very good. Can you point to the doggy? Where's the doggy? Oh, right there. Okay, where's the horsey? The horsey is? Right there. Okay, where's the birdie? Where's the bird? Where's the bird? Can you point to the bird? Where's the bird? Can you show me the bird? Where's the bird? Where's the bird? Show him the bird. Can you show me the bird? Where's the bird? Yeah, good job. Can you show me the kitty again? Where's the kitty? Where's the kitty? Where's your nose? Can you touch your nose? Where's your nose? Where's your nose? Okay. Where's his nose? Where's his nose? Okay. Where's his eyes? Very good. Where's, okay. Where's his mouth? Mouth, very good. Where's your mouth? Can you show me your mouth? Where's your mouth? Can you show me your eyes? Okay, look at him. Where'd he go? Where'd he go? Where is he? Where is he? Where's he now? Where is he? Oh, he's way up there. Look at, he's way down here. Oh, where'd he go? Where'd he go? Oh, here he comes. Oh, here he comes. Good. Oh, that's a good spot. Can I give you that? Do you like that? Here you go. And would you like this? Do you like that? Can you put him in there? Very good. Good. Can you put that in there? All right. How about this one? Good. All right. How about that one? Good. Okay. Put that on top of that. Can you put it on top? Very good. Good job. All right. Good job. Another one? Do another one? Here you go. Do another one. That's about it, huh? You don't want to do this one? All right. Good job. Another one. That's pretty high. Can you do that? Good job. Do it again. Do it again. Put that on. Two things at once. Have you started to have a hand preference?
I haven't noticed he uses anything, it seems like his right hand.
Right hand, okay. Do you want to draw? You want to draw? Okay, ready? Go like that? Okay. Very good. Okay, can you do this again? Can you do that again? That's very good. All right. Do you want to do it this side? You want to do it that hand? Good. Where are your feet? Oh, good. Oh, where's your nose? Where's your nose? Very good. Oh, just fold you up. Fold you up like that. Okay, very good. See that horse? Yeah, that's the horse. He's gonna go tap, tap, tap like this. He's gonna go tap, tap, tap like that. And tap right over here. We're just gonna tap on your knees down here. Okay. Oh, it works. And tap on this one. Yeah, that works too. Oh, and we're gonna just tap on your knee.
Okay, so I think you saw some of the things we were talking about in the video, right? About how to assess drawing skills, about how to use blocks, how to look for hand preference. There was receptive language. You saw the baby telling some words, and then about showing body parts. Then trying to get him to throw the ball. He couldn't kick the ball because I think he couldn't. Throwing the ball comes first. So like that, I think you had some idea about what goes on when we assess development, different domains. And we also look at the eye contact with the examiner, the ability to pay attention, all that, right? So the whole video is uploaded again. You can have another look, right? So moving on. If we check a child between 2 to 5 years, the gross motor assessment, we have to assess the ability to stand. So stand on one leg, stand on tiptoes, walk with a wide base gait or feet slightly apart, walking around corners, running with confidence, jumping, hopping, stairs, walking up and down, climbing, using bicycle or tricycle. Then the fine motor assessment is about what we saw, something like that, building a tower of bricks, building a bridge, a train, right? And then we have to look at whether they have palmar grasp, whether they have pincer grasp, are they able to hold two things at the same time, are they able to release, are they able to copy, are they able to build from the beginning, all that. So once we remove the bricks and then we can offer a book, we look at how they hold the finger, how they hold the pencil, and whether they can open the book, how many pages do they turn at a time, can they copy lines, can they imitate strokes or circles or squares, right? And we can, the older child, we can ask them to draw a man, we can demonstrate threading beads and offer the beads to the child for them to do it. We can test the child's ability to use scissors. So these are based on the normal development, right? Depending on what they can do, you have to offer them the next skill, right? To make sure we are doing age appropriate thing. And we can also see whether they can tie their shoelaces, so on and so forth. We can try to play a game with him, see whether he can take turns, show concern for the others. Then meal times, whether cutlery can be used. What about, you can ask parents information about toilet training, dressing, undressing. Then we also talked about play when we talked about normal development. So do they engage in pretend play? So we actually give them a small doll and some say teacups and various things to see whether they actually do pretend play. Does she follow rules? And then again, board games or different games. So can they take turns? Right? Can they identify colors? Can they solve simple puzzles? Right? So that is basically on how we check the development in children, right? So there are more videos also about how to check for autism. All the videos are uploaded in your LMS. I think it will make it more interesting and easier for you to remember and understand if you watch the videos as well. Does anyone have any questions? Any questions? Okay. So if there are no questions, I think we can end the session. Any questions? Okay, there is a question. Hold on, I'm trying to get to chat. Okay, how child assessment is done during quarantine period? Are these assessed in the private sector? No, these are assessed when they come to the clinic, but at this time, clinics are also not held much. So if the midwife is visiting the home, it would be done. But otherwise, it is happening less. I mean, detailed development assessment, like what I showed you on the video, is happening less in our clinics right now, because unless there is a major issue to come to the clinic, things are happening at home. But people who are having issues, developmental assessment is not an emergency most of the time. So unless we have a referral and there is a one with a delay, then yes, this will be done. Even now, taking precautions, but it's not going to be easy wearing all those clothes. right? So what we use, even our clinics are not functioning the way they used to right now. So no, it is not only happening in the private sector. All the videos are stuff, they are not my own videos. I have borrowed them from the internet, but I do all these things in the normal clinic. Right, but not for all children, because as you can see, it takes half an hour to 1 hour to do one, right? So we give appointments and we do this actually. Sometimes it is done for research purposes, but also it is done if there is a need for a full development assessment, it is done in the usual clinic, but of course not in the busy clinic. We have to get a separate room. If you have seen the DMH clinic, actually I do it in the medical clinic when when the mother's other things are not happening. So you need a separate space, because if there's a lot of noise and a lot of people going here and there, baby will be distracted. So we can do it in the clinic in a separate room. That's how we do the speech therapy also. So whenever you come to our place, you can have a look. The preterm child is expected to show same milestones at same chronological age. It's like this. In a preterm baby, you have to take the corrected gestational age. So for example, if a baby is born at 32 weeks, you take term as, let's say, 40 weeks. So the baby is 8 weeks behind, right? So a baby, when he's, let's say, preterm baby born at 32 weeks, presents to us at 2 months, right? So although the chronological age is the age from the birth to now, is 2 months, corrected gestational age is actually 0 or birth, because he was born 8 weeks before. So although it's 2 months, now only the baby has reached term. So we expect that baby to do things for term only. Let's say if that baby presents at 4 months of chronological age, we expect him to have a developmental age for the corrected gestational age. Corrected gestational age in that situation will be 2 months, because it's 4 minus 2, because it's 8 weeks equals 2 months. Right? So this correction is done until 2 years of age. After 2 years, they are supposed to have caught up. So no more correction from there on for preterm babies. Diduli, did I answer your question clear enough?
Yes, madam. Thank you.
Okay. Then if the baby has the potential but the parents haven't taught them, are these skills naturally acquired? It depends on the stimulation, Shanaya. So if you stimulate the baby, that is why it is important that parents spend more time with their children within the first 2 years of life. One thing is breastfeeding and giving good nutrition, complementary feeding, all that, but also early stimulation. So it's important that every day there is at least some time of the day is dedicated to talking to your child, showing books, doing some puzzles, all that. It will be enhanced and improved much with stimulation if the parents don't do anything and just keeps the child in some corner with a servant who is not doing anything but maybe putting the TV or talking nonsense. Then yes, even a very intelligent child's skills will be blunted. Right? So all these skills will be enhanced with good stimulation, and that is a message you have to carry across to your personal life for your own children as well as the patients you care. Shanaya, clear enough?
Yes, madam.
Okay. So Madhushit, these are not only done in the private sector, right? All of this can happen in the state sector, but it doesn't happen for all babies for the obvious reason that our clinics are overwhelming. So if we want to do this, and you can do a rough assessment without going into such detail, but if details are required and if that needs to be done, we give appointments and it is done in the public sector. Any other questions before we wind up? Okay, so there is another question from Hansini. What if the baby skips some milestones in one domain but achieved advanced milestones in the same domain? Does it consider? Okay, now it's like this. Milestones have a sequential order, right? But there are some milestones which can be skipped. For example, like I think you have asked about crawling, right? So crawling is not a necessary milestone, whereas head control, sitting with support, sitting without support, standing with support, those are necessary milestones. But crawling, creeping, they don't happen in all children. So the sequence has to be there. Someone who didn't reach head control cannot sit. Someone who didn't sit cannot stand. Someone who didn't stand cannot walk, right? So there are some necessary ones which cannot be passed. But things like crawling and creeping can be missed, and they are not necessary, and the child can go on to the next one. Hansini, is that clear enough?
Yes, madam. Thank you.
Okay. Any other questions before we wind up? Diduli, your hand is up. Any question?
No, madam, it was a mistake. Sorry.
Okay, no worries. Anyone else? Any questions before we wind up? If not, we can wind up the session. Thank you everyone for participating. Try to go through the stuff in your LMS. And would value your feedback also later on how to improve, because it's our first time putting everything online. Okay, all the best then. Thank you.